The numbers are impressive. In 40 years, from a storefront clinic on Main Street, Middletown, Connecticut, to a statewide organization that provides sophisticated primary medical, dental, and behavioral health services, 800 staff serving 130,000 patients in over 200 sites across the state. Embedded in those numbers are tens of thousands of stories, heartwarming, heart-wrenching, tales of people who had been denied access to care, whose lives became better. The numbers are impressive and the human interest stories compelling, but this is a different kind of story. A story about how change happens, deep systemic change, change that has the capacity to deliver consistent, dependable care, to innovate in a field where technology and treatment offers new opportunities. I'm Margaret Flinter. 3 decades ago, I arrived in Middletown, Connecticut, fresh from the Yale School of Nursing, a newly minted family nurse practitioner, and joined a small staff in meeting the needs of a population that had been routinely underserved. Remarkably, the founder, CEO, Mark Maselli, and the only family practice physician, Carl Lecce, and I are still around, now 3 of 800. Carl is one of the most respected primary care physicians in the state. Mark is a brilliant strategist behind our institutional growth, and myself as the leader in our clinical and programmatic development. Our organization, the Community Health Center, Inc., is funded through a mix of sources: sliding scale fee-for-service payments, payments from private and public government insurance, and grants. We respect the bottom line of running an efficient business that's now $70 million in annual revenues, and we're devoted to providing a critical service to our communities. Our organization is one of 1,200 federally qualified health centers across America, which, in aggregate, really are the core safety net for healthcare in the United States, serving 20 million Americans. What we do and how we do it matters. Primary care matters. If it's delivered efficiently, if it moves upstream to address the root cause of illness, to reduce chronic disease and the impact of bad habits and poverty, then the spiral of costs can be moderated. And now to our story of systemic change. Our replication model establishes semi-autonomous sites that are linked by centralized leadership and administrative services and have been strengthened as we adapted to changing opportunities. These are some of our buildings. They're spacious, they're well-designed, they reflect our model of care, and they demonstrate to our patients, rich or poor, that we value them and that they are respected. Let's do a rooftop garden. Let's have something that environmentally is just spectacular for the community. Something that when people come and visit, their preconceived ideas about what is a community health center, what is primary care, will be blown apart, and maybe they'll come to a new vision or a new understanding of primary care and community health as something that's exciting and dynamic. I want to share with you some of the key innovations that have been foundational in building this model of care that transforms both the patient's experience of care and leads to improvements in clinical outcomes for individual patients, for whole panels of patients, and for neighborhoods and communities. And I'm going to start with something that is so important to patients and so important to the outcome of care, and that's advanced access. If you were to call the Community Health Center, your call is answered by any one of our patient service associates across the state who are operating under a guideline of doing today's work today. That system has led to dramatic increases in patient satisfaction and, most importantly, in our being able to make sure that we respond to the clinical needs and the needs of patient preferences as they arise. And, of course, it's good for business. So when the patient arrives at the health center with that appointment, we try to continue that rapid access, minimizing waits and delays, and you'll see that the kind of technology that we've built is the same kind of technology that we've come to expect any place we get service: at the bank, in the airports, so you can get on to the business of what you really want, which is to see your provider. Because clinical laboratory services are such a critical piece of primary care, we bring our lab service right on site. We partner with Quest Diagnostic Labs, tremendous partner for us, made laboratory services available at no charge to patients under 200% of the federal poverty level. But most importantly, for patients across the spectrum, having lab services and phlebotomy right on site means that the lab work actually gets done and gets done in a timely way. So that by the time you finish your appointment with the nurse practitioner or the physician or the PA, the order for your labs are entered electronically, and by the time you can make it from the second floor to the first floor, those orders are received. The lab work can be done right then. Everything comes back electronically, interfaced directly into the electronic health record, and available for your provider to review, make decisions, and plan that next episode of care or treatment change. And you'll see it throughout the building, bringing not just medicine and laboratory, but behavioral health services, dental services, nutrition services, and a whole range of other care. And that model of care was built upon multiple innovations, some of which we created, many of which we learned and borrowed from other people and took to new levels. It can't just be that we at the executive level say, we've decided that teamwork is the way to go. To make it happen means engaging people all throughout the organization, laying out why we're doing it, engaging them in defining what that workflow in the process is, figuring out with support teams who's going to be responsible for measuring and monitoring our progress toward it, and then doing the hard work of sustaining and spreading those changes and innovations through all that infrastructure, policies, procedures, so that whatever the generation of smart people is that figured out how to do it, it becomes part of the DNA of the organization. Standing in the clinical hallway of one pod. That clinical hallway is where patients on the panels of the primary care providers in that pod can expect to get all their care, and pretty much from the same group of people. So let me tell you about how we've made some of these real. The first is the integration of behavioral health in primary care, making it possible for patients to go in the form of a warm handoff from a visit with their primary care provider, where the need or the desire for behavioral health intervention is noted, to seeing a behavioral health provider right in the same pod, right in the same complex of exam rooms as primary care is happening. And of course, the net result is there's 0 no-shows for that initial visit, as opposed to the 50% that we usually see. From there, they can get to group treatment or short-term intervention, behavioral health, motivational interviewing, whatever else is needed. It's also meant bringing certain services into the pod, into the primary care pod, that previously were not part of our model. But when you look at chronic pain or an acute pain as one of the #1 reasons people seek primary care, adding chiropractic to our range of services became a core intervention strategy to address a problem that was high frequency and high burden in so many of our practices. And if we look at other exam rooms, there are other innovations which are essential in primary care because the world we live in is such a global and diverse one. Things like having language line access in every room, the ability to press a speed dial button and get a medically trained interpreter in any language for people who come from all corners of the globe. All things which ultimately contribute to better care, more satisfying care, more effective care. And of course, it's all leading up to the pod, which is really the center of life, the clinical microsystem, if you will, in primary care. If you want people to behave like a team, interact like a team, think like a team, create a team environment for them physically. Every day starts with a huddle with the people on that panel, the provider, the MA, behavioralist, nurse, looking at who's coming in today, looking at what needs to be done for those patients, who needs more attention because we know they've recently been in the hospital or because they're not doing well in terms of controlling their chronic illness, making a plan for a day. And all of that contributes to both the rationality of the care we provide, the completeness, but also the vitality of the team. You can't get very far in one of our buildings without seeing large, colorful posters that say change begins with a group. We recognize that social isolation is a huge concern for many of our patients, and we've taken that now and said, that's not just about behavioral health, but really that's about medical as well. And so the shared group visit has been one of our key innovations that we've put a lot of focus on this year, about creating shared medical visits for patients with diabetes first, but looking to expand that to parenting and well child care. Community health centers probably are the leaders in the country in the integration of oral health and medicine and behavioral health. We develop dentistry in all of our sites, not just preventive dentistry, though we do a tremendous amount of that, but also full scope restorative care. And like everything else, integrated into our electronic health record so that the patient has one common electronic health record. Social history, family history, medications, allergies. Technology has been our friend, not just the electronic health record, but video conferencing between all of our major sites as a basis for coordination, shared work projects, and quality improvement. We use video conferencing as well to connect with teams of specialists through Project Echo to get their wisdom on treating our most complex challenges. All around the country, when I talk to people about innovation, the second question after asking how you do it is, how do you pay for it? What's ironic is that many of our innovations are directly tied to absolutely reducing the cost of healthcare throughout the whole system, but there's no policy that allows for there to be payment for us at the moment. I would argue that investing in innovation, investing in research, investing in training are as core as investing in materials and supplies and staff. And fundamentally, that starts with leadership. And a commitment that if you're going to be in the business of primary care, that you have to be in the business of improving primary care, of studying primary care, and of sharing that knowledge with other people. In 2005, I created something called the Weitzman Center, which I envisioned as the research and development, the R&D arm of the Community Health Center. When we recruited our former Chief Medical Officer, Dr. Darren Anderson, back to the health center in a new role as our first Chief Quality Officer, he brought with him a fierce commitment to developing a program of research that was focused on the science of quality improvement, the science of delivery system change, and addressing some of the most challenging problems we faced, like chronic pain. Out of Darren's work has grown the Weitzman Quality Institute, now collaborating nationally with multiple partners on innovations and quality improvement. Also envisioned it as a place where we could bring together the best thinkers in the country to come together and say, what do we have in common? And out of that came the annual Weitzman Symposium, which is now going into its 9th year. The Weitzman Symposium has developed this entire almost body of knowledge and almost a history of innovation in primary care in the United States over the past decade. From San Francisco bringing us the idea of the e-consult, or Sharon Rising bringing us the idea of centering pregnancy.
One day somebody asked Wayne Gretzky, who was the best ice hockey player in the world, he said, why are you the best hockey player in the world? And his answer was, because I skate to where the puck is going to be. And that's what Mark and Darren and Margaret do. And that's what makes them special. And that's why I really believe that what you're doing here can be a model for the rest of the country.
And the Weitzman Center then became home to some of our most cutting-edge work. Out of our thinking was born the country's first postgraduate formal residency training program for new nurse practitioners, now in its 7th year and with dozens of replication models across the United States and other community health centers. Our experience there, the experience of watching the graduates of that program transition seamlessly into roles as primary care providers in other organizations, has driven us to try and change policy, to create sustainable funding streams, and to build a sustainable future for residency training programs. In the setting of the Federally Qualified Health Center, Rick Smith from the National Health Service Corps is with us today. It's particularly striking. 6,000 vacancies today as we stand here for primary care providers in the nation's community health centers, 1,000 of those specifically for nurse practitioners. We know that the physician trend continues to be towards the specialties and away from primary care. But this is not about one group doesn't want to do it, so another group will. This is about nurse practitioners historically have chosen primary care as their area of practice, as their domain of concern. But when one meets up with the demands of being the primary care provider for a full panel of patients, that's a very difficult transition. Our goal is to make sure that they get that interdisciplinary, collaborative, team-based, high-performance, model-based understanding of what primary care can be, but also really what primary care is today in this community health center. If we reimagine the paradigm of the relationship between specialists and primary care provider and say the role of specialists is to continually deepen the expertise and the range of primary care providers. Now we've really looked at primary care in a very different way. Care which is for all but the most unusual and complicated of conditions. Care that is delivered close to where people live, work, play, and pray. Care which is affordable to the society as a whole and is acceptable to the people in their neighborhoods and communities. This is primary care. This is the primary care of the future. This is the future that we're creating at the Community Health Center.